All right, so now we're going to focus our attention on borderline personality disorder. So this one is also can get people into some trouble with their relationships. So just quickly going over the criterion for it. There's a pervasive pattern of instability of interpersonal relationships, self-image, and affect, and marked impulsivity beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following. Frantic efforts to avoid real or imagined abandonment, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation, identity disturbance, markedly and persistently unstable self-image or sense of self, impulsivity in at least 2 areas that are potentially self-damaging. So, and those can be areas of spending, sex, substance abuse, reckless driving, binge eating, recurrent suicidal behavior, gesture, threats, or self-mutilating behaviors, affective, so like the range of mood instability due to marked reactivity of mood. And this is usually intense episodic dysphoria, irritability, anxiety, usually lasting a few hours and only rarely more than a few days. Chronic feelings of emptiness, inappropriate intense anger or difficulty controlling anger, transient self-related paranoid ideation, and severe dissociative symptoms. So one of the reasons why they used to call this, or it got the name borderline, is because sometimes the symptoms themselves would sort of jump over a little bit close into the just enough there where they wondered if the person was having some like mild psychotic symptoms in some way. So back in the day when they used the words neuroticism versus psychoticism, this was sort of like, the person would sort of fall in between those. So that's where they came up with the name borderline for it. So basically, in addition to sort of the mood instability, as they were talking about in the criterion, these individuals will typically, when it comes to the relationships, when it talks about idealization and devaluation, it's like they can see the object of their love or care as being like, they'll put them up on a pedestal, and then they can be trashing them, shortly thereafter. So kind of moving back and forth between kind of those extremes. So that's kind of one of the hallmark features of it. So, all right, let's see where we're at here. All right. So we talked a little bit about the impulsivity. So just like the antisocial, there's the sort of the impulsive side, although this one affects more of like self-image and mood itself. When I talk about affective instability, usually it's intense emotional responses, usually in response to environmental triggers, but it takes them a while to come back to baseline after they get pretty upset. When you add on to that they have a really highly unstable self-image, it really can make them sort of unpredictable in that way. And then there's the sort of not thinking about long-term consequences. So they will sort of act out in that way. So those are things that can be really challenging with this group. So in practice, these individuals can be very difficult to treat because they do engage in a lot of self-injurious behaviors. Those behaviors, they can use the self-injurious piece for a number of different purposes. For some, it can be a little bit of secondary gain. We talked about in an earlier class how sometimes they will go, starting off very young, they don't really get that response that they want. So something happens, it's very upsetting to them, they show an emotional response, they don't get the reaction from it. So sort of that feedback loop that tells them, hey, it's okay to have an emotion. So the expression becomes bigger. When that doesn't get it, the expression keeps getting bigger and bigger until, they're like screaming with a neon sign and that. So, that being the case, when they are interacting within their relationships, sometimes they'll go very quickly to the neon sign. And when somebody does treat them well, it's almost like sometimes they don't know how to react to that. So, in day-to-day practice, what you'll see is that sometimes they will act out the most right after you introduce them to relaxation techniques and other things, because it's almost like there's a little part of them that's saying, I'm not used to this, so I'm not used to somebody treating me this well and everything else. And in some ways they might be sort of drawn to chaos in relationships. So when somebody's acting maybe not so nice to them, they seem like they're more drawn to that. So it almost seems kind of backwards, like the wires get a little bit crossed in that way. So, and a lot of people, they'll get frustrated with working with this group of individuals, but they can also be very interesting, very charming to work with. They can be, sometimes those interactions, can be pretty positive in that way. And we can say that about a lot of the personality disorders as well. We tend to focus more on sort of like the pathological symptoms or the ones that get them into trouble. But, when it comes right down to it, they're human just like anybody, and they have their good points and their bad points. These are just things that really get in the way of their life in a lot of ways. All right, so along with the high levels of impulsivity and those mood swings and that sort of thing, you get the erratic self-destructive behaviors. You can see why sometimes when people are trying to figure out the diagnosis, they will give them other diagnoses in their place. So sometimes it can lead to sort of going back and forth, and maybe early on they'll get a diagnosis of ADHD or bipolar, one of the bipolar conditions. So sometimes when they engage in self-injury, sometimes it's visible, sometimes it's not so visible, even for the non-suicidal cutting that happens. So quite a number of patients I've worked with, they will cut themselves in places that are not visible. And they're doing it very much because they're not necessarily reaching out for attention as much as there's something very grounding about the experience. It makes them feel a certain way, it makes them feel positive. Or they feel more like they're alive during that time. So, which may not sound typical to most of us, but there's something that they gain out of that experience. So, pretty much as far as the population go, about 1% to 2% of the population, overall population, could qualify for a diagnosis of borderline personality disorder. As we talked about before, sometimes a person can have the traits of it without having the disorder itself. Same with this one as well. Up to 75% of people with borderline personality disorder can have cognitive symptoms or episodes that almost have like a psychotic-like pattern to them, even to the point of having some hallucinations for periods of time, or paranoid ideation, or severe dissociation during times. And although that's not typically the norm over the long term, with those periods like that, once again, that's why it sort of got the name of borderline, where it sort of borders between that neurotic and psychotic side of things. So as far as comorbidity with other disorders, some will say that this condition is a little bit unusual in that it tends to kind of link itself up with both internalizing disorders. When we say internalizing disorders, the ones where it goes back on the person themselves, like anxiety, depression, and externalizing disorders where they take in things like substances, that sort of thing, and also acting out towards other people. Substantial co-occurrence with other personality disorders, so they can have either at least symptoms or traits of some of the other conditions, some of which we've talked about already, like schizotypal, dependent personality disorder, things like that. So, biologically speaking, you have about a 4-time more likelihood of having borderline personality disorder if you have biological relatives. So you're 4 times more likely to have it. So there's at least some connection there biologically in that way. So there is some research focus out there on the neurotransmitters related to serotonin and dopamine. So just something for your charts to put in there as well. So once again, we talked about like the sort of the stress side of things, the amygdala side of things, and where a lot of that piece comes from. So we do see increased amygdala activation in emotion-inducing situations, as well as reduced prefrontal regulation. So remember, that frontal cortex, that's more about like that higher thought process, and the amygdala is more that primitive sort of stress response that you get in there. So you see that interaction, kind of like when we talked about in class about the stress reaction, that stress diathesis side of things. So early stressful experiences affect that hypothalamus, pituitary, adrenal axis, that HPA axis, and may make a person more susceptible in the long term to not handling stress as well as what they could. All right, so as far as treatment goes, probably compared to a lot of the other personality disorders that we talked about, this one is pretty interesting in that it probably has some of the most researched treatment around it. So primarily there's going to be the use of dialectical behavioral therapy. So DBT, which is a variation on cognitive therapy. It is meant to be changed a little bit so that it takes into account sort of the emotional states. It focuses a lot on teaching a person some self-soothing behaviors. So we talked about how when they're young, they don't get that sense of self-soothing from maybe their caregivers. So you're in essence trying to help teach that person how to develop some of those skills for themselves on how to sort of self-soothe in those kind of difficult situations. There's a little bit of an emphasis on mindfulness in that process. So actually even the term dialectical, it kind of refers to a couple aspects of treatment itself. We use the word dialectic when we're talking about language, so there's a big focus on how that person talks to themselves. And a dialectical usually refers to the two polar extremes of things. So much in the same way, we're working with the person on learning how to work within those extremes of emotions. And that's so a lot of the skills that they learn, a lot of those sorts of things will be part of that. So, and it is found to be pretty effective. The treatment has to be very focused on getting the treatment team very consistent with each other, having some sort of structure to the treatment. So, because as you can imagine, these individuals can be more frequent users of emergency rooms, having some suicidal ideation, that sort of thing. So it has to be a very consistent treatment regimen that's sort of really you have 1 or 2 individuals you're really focusing on coordinating their overall treatment. So more to follow on that. All right, well thanks. That's all we're going to talk about right now for borderline personality disorder, and look out for some resources within Canvas that can kind of go over some of the other personality disorders as well.